how guidelines came about and so on, and what they meant, and then a big apology as to why they differ in how to treat the two things, and so on. A big apology and so on, and are there any journals in that bag?
Not really June.
By the way, I just had a letter published in
There's one here, this,
something called the ACP Internist, and this is exactly no. This is about drug pricing. For your interest, I just had a letter published in the ACP Internist, which is my first publication since I was in medical school. Which, those of you who are interested, it's about abdominal pain and so on. Then a little comment. 2017, this is very recent. 2017 Infectious Disease Society of America Clinical Practice Guidelines for the Diagnosis and Management of Infectious Diarrhea. That's the title. How many pages do they have? Anybody want to guess how many pages? 94. 94 pages describing what you should do with infectious diarrhea. So that, you don't want to read through that. I certainly don't want to read through that. And I'm going to look through this one more time. I promise that if I can't find it right away, I will do it before the next session, which will be in January because of Hanukkah. And I think that's what we're going to have to do. Because it's sort of interesting. Questions?
Are you going to get tenure now?
two questions on the CA 125 that you mentioned, false positives. Is there anything known about false negatives, or if you get a negative, it's negative?
There are false negatives, a lot of them, which is one problem. And there are false positives also. And the question is, what do you do when you get a false positive or an elevated level and you get a normal sonogram and CAT scan? What do you do about that?
And a false negative?
False negative, you're
You're back
up
to
the creek without a paddle. You just have no way, you're back to square one. But, if you have any suggestion that you may have something going on down there, then you get another one in the next year, which is what a lot of them do. And in fact,
the other question was, you mentioned that with Medicare in traditional Medicare, 2018, and then progressing further into 2019. 2018, that's already confirmed and passed that they're going to be going with prior approval for certain procedures?
in 2018, what's going to happen is they're going to ask for prior approval, but you can bypass it. In other words, nothing's going to happen. But in 2019, they will require it, and they're trying to push it off to 2020. Oh, just one more thing about Medicare and so on. And this was actually covered very nicely in the New Yorker a few years ago. The average price, well, the average amount of money spent on traditional Medicare patients in Lubbock, Texas, is approximately 2.5 times as the average amount of money spent on people with traditional Medicare in certain parts of New Hampshire. In other words, what is happening is, what's been happening for years, is that doctors in Lubbock, Texas get angiograms, CAT scans, MRIs, and various other things that anybody walks into their office and get away with it. And people who go into their doctor's office in New Hampshire get treated as if, well, you don't need that, why bother, and so on. We're not here to make money. Very recently, I got a letter about a patient of mine who surprisingly isn't here tonight, and he went to see an ear, nose, and throat doctor who happens to have a CAT scanner in his office. He went there basically with a cold, and he had a CAT scan done of his sinuses. I took the letter that I got about that and wrote on it, why did you do a CAT scan, and faxed it back to him. I have not had a reply yet, but if we don't do something about this, we are going to have problems. Incidental homeless, Mark Herskowitz isn't here tonight, unfortunately. we've touched on incidental Very often when you do a test that's not necessary, you find something on the X-ray, CAT scan, MRI that is incidental to what you were looking for. And you are obliged to evaluate it. And this becomes a problem. One patient of mine very recently, this month, went and had an indicated CAT scan of her abdomen for some pain that she had. And they found something in her chest. The chest always shows up a little bit in the abdomen, which looked like a cyst. And they recommended getting a CAT scan of her chest dedicated. So she got another set of contrast, which is not necessarily good for your kidneys. And they said on that one, the radiologist, they have to amortize their machines, understand. Radiologist said, we really need an MRI with contrast. She came in and she says, I'm not doing it. And I said, I agree with you. We'll get something, the thing is big enough, so if it's really bad, she's in trouble no matter what you do. So, but it's not, it's benign. Everybody knows it's benign, but since there's a 2% chance that it's not, the radiologist recommended be very careful of things like that. Unnecessary tests have gotten people into big trouble. Further questions?
Gout, where's the gout?
Pardon me?
What happens to the gout?
It's out. Is this it? No.
You could just cut it.
I can't believe I don't have it. Because I wanted to read that. First of all, these guys, it was written so beautifully and so nicely that oh, wait. Yes.
Yay.
Yeah, I didn't circle it on here. That's why it's not here. Okay. Gout, the most common form of inflammatory arthritis, and if you have a hot joint, that's what it is until proven otherwise, has a well understood pathophysiology and effective treatments are available. Yet, gout is poorly managed, with approximately 70% of patients having recurrent flares. Elevation of serum urate levels to above 6.8 under normal conditions can lead to monosodium urate crystallization. Its hyperuricemia is not a mere comorbid risk factor of gout, but the main feature. It is in this context that we review the ACP, American College of Physicians, guidelines for gout diagnosis and management and the accompanying systemic literature reviews. We agree with the author's conclusion that a high strength of evidence exists for use of colchicine and so on to treat this. The authors suggest that a reactive treat to avoid symptoms approach may be a reasonable strategy with ULT, which is a high uric acid level, instead of a proactive treat to target strategy, which is what the American College of Rheumatology recommended, and so on. So they're basically saying, don't knock the uric acid down and so on. And they write this editorial. Holy shoot, they're voting for this actually. Wait a second. This whole thing explains how they went ahead and decided what they wanted to do. And where's the Caucus part? So the new clinical guidelines on the advantage of the ACP as opposed to the ACR rheumatologist guidelines. Let's start by considering the definition of guidelines. In 1990, the Institute of Medicine released clinical practice guidelines directions for a new program. By the way, if you look in Amazon, this will cost you $500, in which it defined CPGs, clinical practice guidelines, as systematically developed statements to assist practitioner and patient decisions about appropriate healthcare for specific clinical circumstances. The 2011 Institute of Medicine report updated this definition as follows. Clinical practice guidelines are statements that include recommendations intended to optimize patient care that are informed by a systematic review of evidence and an assessment of the benefits and harms of alternative care options. Furthermore, the 2011 report, Finding What Works in Healthcare, Standards for Systematic Reviews, explicitly established definitions and standards for systematic reviews as rigorous, protocol-driven literature reviews that summarize evidence and help clarify what is known and what is not known about the potential benefits and harms of treatments. The Institute clearly distinguished systematic evidence reviews from other types of literature and so on. And they will go ahead and going on for 3 more columns, describe the difference between what they feel is the right thing to do for gout, which is, it happens, as opposed to what the ACR says. Now you can imagine the difference. This is a relatively, it's not rare, but certainly less common disease than high blood pressure, than diabetes type 2 particularly, than coronary heart disease, and so on. Where there are many societies involved with the care and not the care of these particular kind of people. You can imagine how many different opinions you might be getting out of this, and how anybody who comes up with a second opinion as opposed to what the first group had to say has to almost apologize for what they're saying, but have to show what their evidence is. It makes it really hard, really hard for each of you to make a decision when your doctor says, do this or do that. Second opinions inevitably lead to different opinions from the second doctor. Very often people listen to the second doctor, be he right or wrong, and so on. And my real recommendation is to each of you, and for yourselves and your kids, find yourself a primary physician, whether it's an internist, a gynecologist, a family practitioner, a pediatrician, a geriatrician, and that you trust. And when anybody says anything, go to see him or her and ask what their opinion is. You got to find somebody you can trust all the time, because there's lots of people out there trying to lose your trust. Thank you.
Thank you, Dr.